Okay, sorry about that. Good morning, everybody. It's a pleasure to be here. My name is Vijay Ravindra. I'm at the University of Utah, and today I'll be speaking on Chiari Malformation and Scoliosis. And the crux of this is what do you need to know? I have no disclosures that are relevant to this presentation. So an outline for today's talk, which will hopefully be short of time so we can catch up and take any questions, is to really, number one, define the relationship between Chiari malformation and scoliosis. We'll talk a little bit about epidemiology, which I think is important in understanding how frequent these types of things occur and how we manage them. So if you have Chiari and scoliosis, what now? What do we need to think about, and how am I going to be managed in the future? We'll talk about some long-term implications, and I'll use a case example early on to really help illustrate the points that we're trying to make, and then we'll take any questions. So a few points and themes to consider throughout this talk, and some of this you've probably heard already, and you may even hear again tomorrow. I know there's a similar talk tomorrow, which is great. Chiari malformation, specifically, we're talking about Chiari malformation type 1. Syringomyelia and scoliosis can all occur in combination with one another. The diagnostic workup requires careful attention to the presentation, the physical and neurological examination, and the imaging findings in detail and in aggregate. Surgery for the Chiari malformation may improve or actually stabilize, and in some rare cases reverse the scoliosis. And if this is diagnosed later on or the scoliosis persists, surgical correction of the deformity, as we call it, can be safely performed. The risk of neurological problems and deficits is very low. It's not zero, but it is low, and with modern surgical techniques can be performed very safely. So let's define the relationship, right? This is important in any setting. So Chiari malformation and scoliosis, I would define the relationship as it's complicated, okay? And the reason is will become apparent in this talk, but it's something that requires a lot of thought. So as you've heard throughout a multitude of talks, Chiari malformation diagnosed as descent of the cerebellar tonsils, usually about 5 millimeters or greater below the foramen magnum. The most common presentation that we see as clinicians and the most common reason for workup is headaches, but patients can also present with an abnormal curvature of the spine, which we call scoliosis, and that's what I'll refer to it as the rest of the talk. So nearly 20% of patients with Chiari 1 have scoliosis, and that's not an insignificant number. When you take Chiari malformation plus the presence of syringomyelia, that number goes up dramatically, and it ranges from 30 to 70%. So it's something we need to really have our antennas up for when we see these types of diagnoses, especially in younger patients. So the pathophysiology of this process, why this happens, is just not well understood. And it's frustrating as a clinician to say that to patients because they want to know why this is happening. We thought we do think it involves some of the cells at the front part of the spinal cord and some of the cells in the middle part of the spinal cord, especially if there's syringomyelia or a syrinx present, because we think that it disrupts the way the muscles that course along the spinal column function, either with too much tone or too little tone, allowing for that curvature to progress and get to a point where it's a problem. And the problem with the whole issue that I'm talking about is that we have very limited high-level evidence to guide our decision-making. So let's look at a case example, and this is a patient that I treated a few years ago. This is a 13-year-old male who presented to me with a history of right-handed, basically hand weakness. It's interesting because his complaint was not anything about his hand. That was more an incidental finding, but he had tons of back pain. And when you really kind of talked to him in the office, he was a quiet 13-year-old kid, but he had pretty significant occipital or suboccipital headaches in the back of his head that really worsened when he was playing sports, and particularly when he had a cold and was coughing, he noted that his headaches got really bad. He didn't have any difficulty swallowing. He didn't snore or anything like that. His physical examination here demonstrated that he had some definite and detectable weakness in his right hand. And when I actually flexed his head forward and pushed down on the top of his head, he felt lightening through his upper arms pretty reliably and reproducibly. He had no abnormal reflexes. He walked in and out of clinic, but he did have a lot of back pain also. So this is an MRI scan that he came to from my office, and I'm sorry if that's not projecting real well. So on the left is a sagittal or a side cut MRI, and on the right is a side cut or sagittal MRI of the thoracic spine. So on the left, you can see that there's evidence of syringomyelia in the lower part of the cervical spine and a Chiari malformation. And on the right side, what you see here is that picture is a little bit funny, right? In the middle part of the screen, there's this dark area. And what that indicates to me is that we're not seeing all the vertebrae in the same plane. So when I see something like this, I need to refer back to some of the x-rays or plane films that have been previously performed. And so here, when we think about spine surgery and specifically scoliosis, we like to look at things anatomically. So left is left on that left-sided picture and right is right. And we see that there's a left-sided curve through the middle part of the spine called the thoracic spine. And on the side view or the lateral view, you can see here that there's an exaggeration of this part of the spine. And you can think about this almost like a hump in his back. And this is what we call hyperkyphosis. And so it was no surprise to me that this patient was really uncomfortable and had a lot of back pain because his muscles in his spine and his spinal column were loading in a way that were making him very uncomfortable. So we did surgery on him. The most pressing issue is usually the highest issue in cases like this. So we performed a Chiari decompression, and he did very well with this type of surgery. He was discharged just after a few days. This is his MRI several months later, demonstrating that his syrinx was partially resolved, definitely trending the right direction. His hand weakness was about the same, no real improvement. And I was very happy with this, and I went and talked to him, and he was not happy because his back was killing him still. And so I said, let's kind of keep following you, and we'll do a lot of physical therapy and see what we can do. And we actually put him in a brace also. And additional MRI delayed demonstrated, again, good resolution of the syrinx, no progression, but still with progressive and worsening back pain. So we studied him again with some x-rays, and he still has this left-sided curvature, what we call a levoconvex scoliotic curvature through his thoracic spine, and hyperkyphosis through the thoracic spine as well. So at this point, he said, listen, I feel really good besides the fact that my back is killing me. I understand my syrinx is better. What can we do? So then we have to think a little bit differently. Then we have to think about trying to release the spine to get him to a better physiologic position so he's more upright and his back isn't as strained as much. And this involves releasing parts of the spine that's, kind of thinking about more carpentry here. So removing some of the bony processes, releasing some of the ligament and the joint capsules that span this area. And so this is where we ended up. He underwent a long segment posterior spinal fusion with multi-level osteotomies, and you can see he's standing up a bit straighter. And his left-sided picture there, the front or the anterior posterior picture shows that we've corrected his scoliosis. And this is him 1 year after surgery. His pain is completely resolved, and his neurological function is stable, and he is happy as a clam. So this is a case that really illustrates what we need to think about in Chiari patients that have syringomyelia, that have scoliosis, and in this case, this is what I'd call kyphoscoliosis, okay? So when you present with scoliosis in the setting of a Chiari malformation, or in general with any scoliosis presentation, symptoms like headaches, back pain, oropharyngeal dysfunction, so those things I mentioned, difficulty swallowing, sleep apnea, snoring, absent or asymmetric abdominal reflexes. All of these things should prompt a further workup for neurological issues, specifically Chiari malformation. When we think about early onset scoliosis, so kids that are less than 10, they usually undergo MRI scanning because the likelihood of us finding something that could be quote unquote driving the scoliosis is quite high. And if something like that is discovered, whether it be a Chiari malformation, a tethered cord, or something else like a neoplasm or a tumor or something atypical, those require action. There's another form of scoliosis that we think about, which is the most common form, happens in young women, adolescent idiopathic scoliosis. And when we diagnose that, MRI scanning is actually very controversial because most of the time we don't find anything. So people talk about, well, is it really worthwhile to put a patient through an MRI scan? Is it cost effective? But we actually find a Chiari malformation up to 8 to 10% of the time. So in my practice, I do it. I can't say that it's uniform among all people that do scoliosis surgery, but hopefully over time, we can kind of come to a consensus on this. So what is scoliosis? Well, scoliosis is an abnormal curvature of the spine, and we look at this thing called the Cobb angle, and it's a measurement between an upper part of where the curve starts and the lower part of where the curve ends, and anything greater than 20 degrees is considered scoliosis, and it needs to be either monitored or require a further workup or treated depending on the magnitude of the curve. Anything less than 20 we think is probably something that we call physiologic, and it certainly warrants follow-up on a clinical level, but doesn't usually require any intervention. So my ears go up when I hear about someone who has scoliosis and they have a left-sided thoracic curve, meaning the middle part of their back, it's the left-sided that's curved because that's what's considered an atypical curve, okay? If the apex of the curve is on the left side too, that's something that clues me in. If it starts early, any child that has a curve that starts early in life, and the earlier it starts, the more worried that I am, that really gets us thinking early on. Neurological deficits, of course, is something that we take very seriously, and if there's any hint of a neurological problem, they need to be promptly imaged and appropriately treated. If there's kyphosis, that exaggeration or that humpback in the middle part or the upper part of the spine is usually an indicator that someone's trying to compensate for something. And we need to figure out what that something is. And scoliosis is all about time, right? We never see a patient with scoliosis and immediately offer surgery in one sitting. This is a long-term relationship. We want to see how that curve behaves over time. If it doesn't change, great. We can say goodbye and see each other in 3, 6 months, or a year. But if it's rapidly changing, we need to understand why and try to prevent that progression from happening. So when we find a syrinx and Chiari malformation, there are certain measurements. We all love measurements when we do spine surgery, right? And people that do Chiari surgery are no different. These measurements are really just indicators. They don't really drive anybody in one direction or the other, but they make us more aware of what the potential behavior is, especially when it comes to the craniocervical area where the brain meets the spine. So when we talk about screening for scoliosis, you'd be kind of shocked to hear that the screening guidelines are not that uniform. If a child has been diagnosed with a Chiari malformation, it is reasonable, and I think that's funny that this is what's in the literature, it's reasonable to test them for scoliosis. Well, how do we test them for scoliosis? We look at their spine. It's pretty easy, right? I have patients lift up their shirt, and then we have them do what's called an Adams forward bending test, where you actually have them bend over and touch their toes. And that is a very sensitive screening tool for scoliosis. If there's any abnormality, rotation of the scapula or the shoulder blade to one side, any obvious asymmetry, then we get a screening x-ray. Low-dose whole spine x-rays can be performed with relative ease at most academic institutions and private institutions. But there is some radiation risk to it, but in the grand scheme of things, it is minor. Okay, so I've been diagnosed with Chiari malformation type 1 and scoliosis. Do I need to see a surgeon? if I need to have surgery, can we just fix both at the same time? These are questions that I commonly get. So I will tell you that Chiari surgery plays a major role in Chiari patients that have scoliosis, and the earlier they present to us, the better. So with scoliosis, there are some patients that undergo a Chiari operation, a posterior fossa decompression, and they can actually halt the curvature of their spine. And in some cases, it can actually reverse the curvature of their spine. So this is something that if there's a suspicion and a diagnosis of these two pathologies in combination, early referral to surgical intervention is beneficial and can be extremely beneficial to the patient. A colleague of ours, Dr. Steve Wong, who treats a lot of scoliosis, he studied 120 patients who underwent posterior fossa decompression, and he found that nearly 33% of those patients had their scoliosis improve because or as a result of that surgery. Now, is it because of some external factor? Probably not. It's probably a combination of things, both environment and surgery and genetics and things like that. But to our knowledge, we think that surgery is beneficial in terms of repairing the Chiari malformation. 20% of curves will not change and they'll stabilize, and that's really with a mean follow-up of 2 years. And stabilization of a curve in scoliosis is fine. That's actually a victory in my standpoint. I want to see that curve not progress over time because that's what's going to drive someone to eventually need surgery. So if I can hold things in place, that to me is good enough. Well, what about bracing? So curves less than 20 degrees may stabilize on their own or regress over time. And this is similar to that other population that I talked to you about, adolescent idiopathic scoliosis. Bracing is something that is labor intensive. Kids have to wear braces from 18 to 23 hours a day. So you can imagine a teenager tasked with that. It's not great, right? But it can be effective. And so in patients that we really think this can work, it takes a lot of teaching and coaching and motivation to help these measures get to where they need to be. What about bracing plus surgery? This isn't that well studied. There's small cohort studies demonstrating that among kids that have adolescent idiopathic scoliosis and Chiari malformation related scoliosis, they underwent surgery and they got braced. They kind of behaved and progressed in a similar manner. So we think it's reasonable to brace these children as well. You know, a big controversy in pediatric neurosurgery is do we need to open the dura mater, that outer covering of the system, the central nervous system that houses the spinal fluid and the brain and the spinal cord when we do the surgery? Well, I think, you know, in this setting with Chiari malformation and scoliosis, basically, we're not sure if opening the dura has a huge effect or not, but I will tell you that some of the studies do suggest that opening the dura does provide some protective effect against that curve progressing over time. So that is a lot of surgeon preference and dependence, and I think if you're getting into the weeds with that with your provider or whoever you're talking to, those are good conversations to have. So why does decompressing the Chiari malformation work? Well, you know, when we think of scoliosis, sometimes we think about it as purely a structural problem. But in the setting of a Chiari malformation, it's probably a structural problem and a fluid problem. And that's why the Chiari decompression likely works, is that there's a plumbing issue where the brain and the spinal cord meet, where the skull and the spinal column meet. And when we do a Chiari operation, the goal is really to restore and improve cerebrospinal fluid flow in this area. And we think that this helps delay the progression or prevent further progression of scoliosis over time. So which patients, you know, that's a lot of information, right? It's a lot of talk about bracing and other things. So which patients should we really be thinking about this type of problem in? Younger patients with smaller curves. Early diagnosis is key. So there are 3 studies here, which I don't need to go through, but 3 studies that really show robust prevention of surgery for scoliosis by decompressing the Chiari malformation. So that being said, if you're diagnosed with Chiari malformation and Syringomyelia, you're less than 10 years of age, you need to have a surgical evaluation. And if you're not a surgical candidate or the person doesn't think it's warranted, that's okay. But to miss that window of opportunity, I think, is a disservice. So I have a Chiari malformation and I have scoliosis. Can I have my scoliosis corrected? Well, the answer is yes. So, when we think about scoliosis surgery, which is a whole different brand of surgery than Chiari malformation surgery, what we really want to know about is safety, right? For the most part, these are elective operations. This is not something that's life-saving. It may be quality of life improving and prevent further problems in life, but it's not life-saving. So we really need to stack the deck in keeping everybody safe and that we're avoiding risk at all costs. So when someone has a sick spinal cord or has a syrinx that could put their spinal cord at risk, we need to ensure that surgical manipulation of their spinal column is safe and the risk profile is very, very low. And what we found is that in patients with Syringomyelia and Chiari malformation who undergo scoliosis correction, it is very safe. It's slightly more risky than the general population, like someone who has adolescent idiopathic scoliosis, but the rates of complications are still very, very low. So the answer is, in experienced hands with modern surgical techniques and appropriate technology use, the surgery is very safe. So although this is maybe a two-step approach, scoliosis can be fixed in the setting. It just takes careful thought and attention. So it's important to understand, and you probably gleaned this from my talk when I talked about some of the evidence and the lack of really higher power evidence, is we don't know everything. We know that timing of surgery and age is really important, but we don't know things about functional outcomes like long-term outcomes in terms of back pain, neck pain, and things like that. Thus far, 5, 10, 15-year data is pretty darn good. But when people get into their 60s and 70s and 80s, are these types of patients more at risk to have problems with their spine? We don't know that yet. We have a lot to be learned about this relationship, and I think now as we're getting better at screening patients with Chiari malformation and having, again, a lower threshold to image patients, we'll get a lot more information and data. But more to come. So I just want to thank everybody at ASAP. This is a great meeting. I might have mentioned earlier, this is my third year presenting. I think this is a very special meeting, and look forward to good discussions later, and I'll take any questions. Thanks.